Our next speakers are Joyce Edmonds and Maureen Farrell. Joyce is an associate professor at Boston College, the Connell School of Nursing, and Maureen is faculty at Beth Israel Deaconess Medical Center and Harvard Medical School's Department of OBGYN, and they'll be presenting on nursing insight and COVID-19.
Thank you for this opportunity to present a snapshot of our work today. Nursing is the largest healthcare profession in the United States, and for the past 18 years, Americans have ranked nursing as the most honest and trusted across all professions. The extraordinary challenges brought on by COVID-19 has really challenged the essential governance of nursing that is embodied in direct bedside care of patients. So we're going to briefly discuss these challenges in the context of Nurse Impact, which is a portfolio of projects which utilize labor and delivery nurse practice data to direct quality improvement. Next slide, please. I first have to acknowledge our awesome team at Ariadne's Delivery Decisions Initiative, our hospital partners, and OB Cope in Washington State. Next slide, please. Labor and delivery nurses attend close to 4 million hospital births in the US annually, and they are the most visible presence, spending more time at the bedside than any other clinician on the care team. And in fact, this time at the bedside, providing labor support and assessing maternal fetal status is thought to be key to supporting safe vaginal delivery and avoiding unnecessary surgical births. The figure on the right summarizes a couple of our key or early project findings. First, simply that there is significant variation in individual nurse-level cesarean birth rates, which signals a quality problem. And then second, that the distribution of nurse rates is similar to the variation observed in physicians. Next slide, please. So based on this data and the knowledge that nearly all successful efforts to reduce cesarean rates have used physician feedback as a guide, we were in the process of developing and testing an audit and feedback intervention for labor and delivery nurses. The basic premise is that extending this QI intervention to nurses could provide an important new lever to improve the quality of care during childbirth. But enter COVID-19, which suspended our person-facing research at hospitals, and we needed to adapt our strategy to account for the impact of care delivery changes that have really complicated the imperative that nurses have to remain at the bedside. So through a planned expert convening and surveying a national sample of nurses, we hope to better understand how alterations in policy and practices in response to COVID are impacting nursing care in relation to delivery outcomes. And I'd now like to pass it over to Dr. Farrell to present a few of our questions. Next slide, please.
So as our team began to ponder what the effect of COVID is going to have, particularly in the arena of labor and delivery, the virtue of trust really bubbled to the top. And as Joyce alluded, the trust in the nursing profession has been omnipresent for nearly 2 decades. And we wonder, with some information that we have anecdotally, whether this trust is changing. First, from the patient perspective, because that bond that they had with this bedside support is no longer there, perhaps out of fear for their own health from the nurse side. To also, we have found that patients are not as forthcoming with symptoms that their partners might be having of COVID-19, knowing that that would then bar them from the hospital. The next questions that arose to us was whether there was going to be a change in the cesarean delivery rates, not only at the hospital level, but at the individual levels. And we could hypothesize why this could be both an increase or a decrease in these rates. An increase in rates, and in order to really optimize personnel resources, and then a decrease in these rates, not only for the same reason, but also because you would want to optimize the material resources such as OR availability and personal protective equipment. Finally, as we consider redesigning care delivery systems, we're not sure how exactly that's going to work in a traditionally bedside, very personal and intimate experience that patients go through with not only their nurses, but their entire care team. At this time, again, I'd like to thank Ariadne Labs and open it up for any questions that you might have.
Thank you so much, Joyce and Maureen. Really fascinating stuff. I think we are really understanding now the influence that nurses have on outcomes. I'm curious what you think the differences you'll see in the different settings, and also how do you anticipate, what do you think will be the largest contributing factor to change care practice?
Those are some great questions, and I think there are many dependencies in terms of overall cesarean rates, depending on the prevalence of the virus in a particular area, the birth volume at a hospital, the availability of PPE, and the unit culture at baseline in relation to childbirth practices. In terms of changes in nursing practice, I think the potential of reduced time spent at the bedside providing labor support, limited use of position equipment like birth balls or peanut balls, or efforts that are in place to minimize the duration of active pushing and delays in response time could contribute to changes in rates. But I'll then turn it over to Maureen, who has some data from New York.
Looking at the hospital levels, we have seen some pretty big differences when we look at Washington State and then New York. In Washington State, they are anecdotally seeing with some initial data that the cesarean delivery rates are increasing, whereas in New York, New York City in particular, they're seeing that their rates are decreasing. And so that made us wonder whether there might be this initial impetus to try to move people through labor and delivery in a more efficacious manner, instead of having a long drawn out labor process to go to cesarean, whereas there might be a threshold point, likely what they experienced in New York City, where that might be your intent, but you might overwhelm the system to a point. This unfortunately leads us to wonder whether there are some unnecessary cesarean deliveries being performed in certain circumstances, but at the same time, are there some deliveries that probably could have been served better via cesarean and they just didn't have the resources, material or personnel wise, to do it, such as in New York City?
Thank you so much, Joyce and Maureen.